Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
We're excited to be sitting down today with Dr. Charles Berde and discussing local anesthetic systemic toxicity, or LAST. Dr. Berde, please tell us something about yourself, including something you enjoy outside of medicine.
Okay. Well, thank you all for inviting me here. It's a pleasure to talk in this podcast. Bit of background. I grew up in Minnesota, undergrad at Swarthmore, did med school and a PhD in biophysics at Stanford, came to Boston in 1980 and never left. Did pediatrics residency at Boston Children's, anesthesia at Mass General, fellowship at Boston Children's, and started doing critical care as my job in 1986. And as a junior critical care attending, stumbled into doing pain management in an era when not many people were specializing in that. And there were some unique and extreme situations where, as a junior PICU attending, I had to sort of stumble through and figure it out. And what resulted in that has been a 40-year career and focus on a number of aspects of pain management in children. That's been my one grown-up job. Aside from working here, doing research, developing novel local anesthetics, doing work on gene discovery for rare diseases and delivery of novel therapies like antisense oligos. When not at work, things like my danger sport, bicycling to work in Boston, running, swimming, reading, being with my wife and my son and daughter-in-law. My wife is an artist, an art therapist, so it is as if we have two hemispheres between us. We are very different in how we approach the world and have been married soon to be 42 years. That's a short version.
Oh, well, thank you so much. And we're so excited to have you here today. I have some colleagues with 30 years of experience, but nobody with 40 years of experience. So this is awesome. So looking back on your career, you've done real hard science, gene discovery, things like that, but you've also done a lot of program development and person management. How do you do both? What tips do you have for aspiring clinician scientists that also need to be program leaders and really develop people?
I wish I could say there's some general roadmap. I think prioritize things that are important. And in picking a area of specialization, area of research, it's the classic cliche, think about what's going to be important in 10 years or 20 years, not just where things are right now. Pick good colleagues who you can collaborate with and trust. Find good mentors, be a good mentor yourself, and try team building. I think those are some ideas on that.
You know, it's a hard question to answer because I think it's so unique to this environment and the circumstance that you find yourself in. Reflecting on what you've shared with us thus far, you've had a rich career and in addition to that, a rich life. And I think the evidence of that is that even after 40 years, you keep coming back to work and taking good care of sick patients and helping others succeed in their career. So it's a real privilege to speaking with you as both an anesthesiologist and intensivist on this topic. Specifically for local anesthetic systemic toxicity, or LAST, any kind of conflicts of interest to disclose?
Yes, and let me just summarize some of those. So along with my longtime colleague and collaborator, Dan Kohane, who's an intensivist here at Boston Children's, have worked on developing novel local anesthetics, a group called Site 1 sodium channel blockers. There is a biotech company formed called AlgaVita Bio. None of the things we'll discuss are in the clinic now, but part of the motivation for developing novel local anesthetics is to avoid some of the systemic toxicities of existing local anesthetics. I'm an advisor to Quiver Bioscience, which is a company making antisense oligos for treating pain, and we just got a NINDS HEAL grant for bringing those from preclinical into clinical trials. There's a company called Latigo Biotherapeutics, who I advise on sodium channel subtype analgesics. There's a company affiliated with Cornell and Columbia that I'm on their scientific advisory board, also on developing novel analgesics. But none of this involves products that are on the market or that are pertinent to today's discussion, except for the general theme of how to get around local anesthetic toxicity.
No, that's great. Thanks for disclosing these. I think it's just more evidence just of your expertise in this field. We'll include these disclosures in our notes. Alice, would you like you to start with the case?
Let's do it. All right. So we're giving you a 3-year-old girl with a history of prematurity. She is taken to the OR for an elective inguinal hernia repair. Following induction of general anesthesia and intubation, patient receives a caudal block for additional regional anesthesia. In the minutes following, she rapidly develops hypotension, bradycardia, followed by a ventricular ectopy. The OR team suspects possible local anesthetic systemic toxicity. So truly, I think as an intensivist, you could really stress me out by calling me to the OR for a code or something like this. Let's talk about what's happening here. So what is local anesthetic systemic toxicity?
Sure. So just to start, though, by saying if that happens at that time, and the timing of it is relative to the caudal, but all those findings, the hypotension, bradycardia, other things, it should go through your mind that there's a differential of it, that it could be local anesthetic toxicity, it could be several other things that can occur on induction, it could be others. But given the timing, given the pattern of it, you suspect the toxidrome of local anesthetic toxicity. So local anesthetics are drugs that cause numbness, and they cause numbness by predominantly blocking sodium channels in their intended site is sodium channels in peripheral nerves or in nerve roots in the case of epidural and spinal anesthesia. There are multiple types of sodium channels in different cells, and if you're a cardiologist interested in rhythm disorders, you think about the subtypes that are found in the heart, NaV1.5 in particular. If you're a neurologist interested in early onset epilepsy, when you get infants in the PICU who are seizing continuously and the geneticist says we've got a variant in a potassium channel or sodium channel. But the issue with the existing local anesthetics is that they're indiscriminate. They bind to sodium channels in nerves, but they also bind to sodium channels in the heart. And when binding in the heart, they cause myocardial depression, they cause slowing, they cause AV conduction block, they cause impairment of repolarization, and the predominant action is on sodium channels. Bupivacaine in particular also has actions on calcium channels. It has actions on mitochondrial functions, but a big part of the action is on cardiac sodium channels. So cardiac toxicity is the one in this case. The other toxicity is CNS toxicity, that in passing into the brain, the idea is that there are balances of excitatory and inhibitory circuits in the brain, and the early signs of irritability and myoclonus and then seizures are felt to represent preferential suppression of some inhibitory circuits. So released from that inhibition, the excitatory action of other circuits give rise to seizures. But under an anesthetic, you won't see that. And if you're a patient sedated in the PICU, particularly with benzodiazepines, you won't see that. You will only see further CNS depression. But that's a little background on that toxicity. And I guess one big point is, and where you see it clinically in toxic events, many of the drugs we give, if you give one dose and you don't get the effect, you give more. If 5 milligrams of morphine isn't doing the desired effect, you give 7, 8, 10. If 4 milligrams of midazolam isn't, you'll give more. Local anesthetics are different. So if you give them and the patient's not numb, or if it's a child in the emergency department you're infiltrating and they're still screaming, numb or not, it doesn't mean you can give more. So the idea that you have to calculate a maximum dose is different from many drug classes that we use for analgesia and sedation and purposes like that. And that's why with a 3-year-old or an infant, it's easy to get to toxicity by the two ways of getting that are either you don't calculate or you miscalculate and you give an excessive dose in a proper location, or, as most likely with this caudal block, it's a very vascular space and you're inadvertently in a blood vessel, you get a first pass phenomenon, high blood concentration, possible synergism with the effects of the general anesthetic, and the combined effect is marked cardiac depression.
That's excellent. We use lidocaine, as an antiarrhythmic and for local anesthetic, so it makes sense that the toxicity would have cardiovascular and neurologic effects. Leaning in a little bit to the diagnostics here, as I understand, bradycardia and arrhythmia is a core feature. Seizures is another core feature of LAST. Perhaps if you're reviewing a case, if you're called emergently to the operating room to help, what diagnostic fingerprint would you expect to see for LAST? And maybe what would be some red flags that might point to another sinister etiology?
Well, I think a lot of it is the context and the history. If it occurs right after injection of a local anesthetic, then you suspect it to be intravascular. We do many cases as combined regional general anesthetic cases, and for major and long cases, there might be a continuous infusion, and so it may be less clear on the timing of it, but I think in the operating room where you don't in general have, if the patient is not awake, you don't have the CNS behavioral signs and self-report signs, then it's hypotension, bradycardia, PR prolongation, ventricular ectopy. Those are the common things.
So it sounds like you're making this diagnosis with a high degree of clinical suspicion, and perhaps you may even be treating at times where it's not quite exactly clear what's going on.
Right. And there are times you're not going to get a blood level back in time. Sometimes if there's an indwelling catheter and you aspirate on it, you'll get blood where you didn't before. Sometimes the person injecting a caudal block should always have an electrocardiogram on, should always be looking at that and looking at indices of perfusion as you go. So, it's possible that your early sign may be a capnograph trace dropping down because of low pulmonary blood flow as opposed to the change in ventilation. But just being mindful as you conduct a regional anesthetic of this possibility. And a lot of it's very age dependent in the sense that, consider a 2-kilogram infant and you're infiltrating for something. If somebody hands you 2% lidocaine, that's 20 milligrams per mil. And so if 5 milligrams per kilo is a recommended lidocaine dose, you do the math. It's very little volume. 5 mLs is a toxic dose, which is another reason for much of infiltration to use 1% or in an infant even 0.5%, but always do the milligram per kilo calculation.
No, that's incredibly helpful. You've already mentioned a couple agents so far, lidocaine and bupivacaine, but there's so many different types of local anesthetics. Which ones are at highest risk or most commonly associated with LAST, and maybe which ones might not be as common?
Sure. So there's a general correlation between the higher potency, higher lipophilicity agents, so bupivacaine, ropivacaine. Ropivacaine was developed with a hope that it would be less cardiotoxic than bupivacaine. It is slightly so. It's also slightly less potent. When you, in animal and human studies, take into account the lower potency, it still comes off a little better, but not as much better as the original claims. But in general, potency, lipophilicity, and the unique receptor binding features of bupivacaine make it the worst. In the other direction, chloroprocaine is an amino ester as opposed to aminoamide, which has the advantage that it's metabolized in the circulation by plasma esterases very rapidly with terminal elimination half times of a minute or two. So if we have a situation of a patient who's had an epidural infusion and we're in the PICU and it's not covering, we're not sure about the physical exam signs of sensory and motor block, we will do a repeat loading dose with chloroprocaine because of that safety margin. Or for neonatal and young infant epidural infusions, chloroprocaine is our routine agent because of that mechanism of metabolism that is relatively mature even in infants.
Oh, that's interesting. Do you think that reflects national practice, or do you think that that's a quirk of your group?
Well, it was an original quirk back when one of our earliest fellows wrote a paper on it with me, Neville Sethna, and others, but it became widely used and was re-argued for by others it's used a lot of places, not universally.
That makes sense. And then if you had to say, okay, we gave you a case with a caudal block, what would you have probably used for that caudal block? Or is it hard to say because everyone's so different?
If we're doing a single shot caudal block with the aim of duration of analgesia, most commonly ropivacaine with additives. And the additive could be clonidine, could be dexmedetomidine in some places, but clonidine is commonly used to prolong analgesia. for single shot, opioid is used, it increases the odds of urinary retention and itching and all the other side effects. But ropivacaine is our most common in that regard, typically 0.2% if one's doing a single shot. What's notable is that if you look at large pediatric registries and case series, the blocks with the highest frequency of LAST have been caudal blocks, and interestingly, penile blocks, particularly urologists either do them by fanning around or by fixed location relative to the base of the penis. And so when you're doing a blind procedure where your only criterion for not being intravascular is negative aspiration, and you're doing it in a place that's fairly vascular, those are risk factors for inadvertent intravascular injection. One of the arguments for using ultrasound, like in the PICU, we use ultrasound for more and more things on a daily basis. And much of regional anesthesia has transitioned to being done with ultrasound guidance. It's one of the cases where the younger and smaller you are, the easier the views are. So my typical Wednesday job is doing lumbar punctures to give gene therapies and oligos, and you don't want any of those to fail. In a 2-month-old or a 6-month-old, it looks like an MRI. The ultrasound view is so beautiful, much more so than a 35-year-old. But for regional, in many locations, you see the needle, you see where large vessels are, and as you're injecting, either hydrodissecting with saline or with the local anesthetic, you can see it spread in the tissue plane, and it's not perfect, but it gives you some reassurance that you're injecting in an extravascular site. If I can just add a point of emphasis to everyone is those calculated maximum doses that you see, where you see 2 to 2.5 milligram per kilo of bupivacaine, for example, that refers to in a proper extravascular site. As little as a quarter of a, quote, safe dose, if given rapidly IV, can cause seizures or cardiac depression. So the key is being intravascular as well as calculating the safe dose.
It seems like we're building a list of maybe high-risk features for developing LAST. You mentioned, of course, intravascular injection, blind injection into a highly vascularized area kind of goes alongside that. Exceeding the maximal recommended dose, even if you instill this into the tissue and not into a vessel. And then infants and neonates. I would imagine it would be easier to overshoot the recommended dose there. What other risk factors should we be aware of? And would you like to put a finer point on any of those?
Sure. So regarding infancy, there are a number of factors. I would say it's the reduced plasma protein binding because of the ontogeny of alpha-1 acid glycoprotein. So more unbound local anesthetic. I would say the neonatal myocardium is probably intrinsically more susceptible, that a greater fraction of the neonate or infant's body is in the highly perfused compartment relative to muscle and other compartments. And for infusions, liver metabolism is maturing through the first 6-8 months of life. And so all those increase risk for neonates and the youngest of infants, so that many of those dosing guidelines are diminished that way. I think one should also be mindful of disease-related risk factors. So all of those things matter, but somebody who has marginal cardiac reserve or congenital heart disease or other cardiodepressant medications on board, myopathies, all those would be situations where the dosing should be reduced and extra vigilance should be applied for that. Those are a few.
Yeah, absolutely. You don't have to tell me twice that the congenital cardiac disease population, right, are single ventricle kids. They don't have much reserve. I'm not doing caudal blocks in the OR, but I do decent amount of lumbar punctures and chest tubes and things where we might want to provide local anesthetic. I really appreciate while you're injecting in these high-risk areas, you're watching the QRS, you're watching your end tidal, and you're looking for any signs. What other things can we do at the bedside to prevent this? Is aspirating back and just making sure you're not in a blood vessel, is that sufficient?
I would recommend aspirating, but realize that it's imperfect. If you're infiltrating in the skin, seeing the wheel as you go, or a moving needle technique. So pediatric surgeons are often taught that if they're infiltrating, the edges of a wound before they close, that if they're moving the needle as they go, the odds of staying in a blood vessel for any period of time is pretty low. So moving needle is one way to reduce that. Using relatively dilute local anesthetic if you can, ultrasound when you can. I think those are a few.
And then say you had the unfortunate event of either an intravascular injection or giving too much drug into the tissue. I imagine there might be quite a difference in the timing related to the dose administration to the symptom onset. Is there a particular expectation that you would have from intravascular injection to symptom onset versus a dose delivered, appropriately, but too much of a dose?
Yeah, I think when it's intravascular, and particularly with rapid injection, it's typically in the first 1, 2, 3, 4 minutes, just because of the time frame of getting into the central circulation and binding to sites in heart and brain. With extravascular injection of an excessive dose, if you look at the pharmacokinetics, people have taken single-shot caudal, lumbar epidural, intercostal, all the various sites, and measured the time course of blood levels. And peak blood levels after a proper extravascular injection, but as a single bolus, typically are 20 to 30 minutes after. So if you complete the block, everything looks great, and then 10, 15, 20, 30 minutes later, events are occurring, it's probably excessive dose in an extravascular site.
I think this can be extra tricky because if you're in the operating room, you say you do your block and then, maybe 20, 30 minutes later during the case, your child starts developing symptoms. Perhaps in the ICU, we give local anesthetic for a procedure. And as we're finishing up and perhaps walking away, the symptoms could develop then.
In fact, if you look at closed claims and case reports of events, it's just that your vigilance is reduced. You've rolled the kid over, you're moving down the table, you're rearranging, the monitors have come off, and then somebody notices that a kid is dusky or not breathing or something like that. So vigilance should go through that time period. You're right. Absolutely.
Just another, along the lines of when we're monitoring and who we need to be monitoring for, what about the risk of someone who's just getting an epidural? Someone who comes back from a procedure?
So when they come back from a procedure, if they've had an epidural infusion running,
yeah.
I think if you are receiving the patient as the PICU attending or fellow and you're getting report, ask yourself, how was it placed? How do you confirm whether it's working or not? What did you give for loading dose? What did you run for infusion? And there are both published papers and apps everywhere of checking your doses. And so as the receiving physician, checking the dose yourself, and then if the kid arrives in the PICU and they're in pain, you want to, well, first of all, are they in pain from the surgical site or are they in pain from somewhere far away? In other words, like any board exam, do a history and a physical first. And are they complaining of pain remote from where the epidural could cover? Are they complaining of pain in ways that have to do with the surgical complication, with sudden rupture of viscera or occluded Foley or occluded chest tube? Go through those. But then for both verbal and nonverbal patients, you want to do a kind of sensory exam. And for somebody who's verbal, you'll be checking, are you numb here, 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 here? And you can do it with a cold swab. You can just take the edge of an alcohol wipe container and say sharp, dull, sharp, dull, sharp, dull, that kind of thing. For an infant, it's often literally tickling the place. If it's a caudal block, the feet should be numb, tickling the bottoms of the feet. And if they briskly withdraw, they're probably not very numb. But you try to get a sense of objective features of block and correlate that with pain behaviors and physiologic signs. But if they're uncomfortable and you're thinking of reloading, you have to have a sense of what the predicted kinetics are and how much one can reload with.
In cases, whether it's, complex surgeries or where kids are expected to have pain after the surgery, our anesthesiologists locally will, do blocks that maybe last 12, 24 hours, perhaps, to reduce the analgesia needed. after surgery. And those kids in the ICU might need additional procedures, and there might come up at least a conversation about, do we do local anesthetic for central line, XYZ? Question would be, kind of keeping things a little bit vague, because sometimes it can feel vague to us overnight on call. If a child were to receive a block in the operating room, what would be some guiding principles about, giving that child additional local anesthetic, perhaps that night following, or what are some pearls to add here?
So on average, a terminal elimination half-life for bupivacaine or ropivacaine beyond 6 to 8 months of age is about 3 to 4 hours. So if they did the block then, one can figure that 3 to 4 hours later, blood level is half peak, and you could safely use half of a full loading dose at that time for an additional block of some kind. Where it may be harder is if they're running a continuous infusion. We try, wherever possible, because of the short duration of blocks, we put in catheters very often. So for thoracic operations, paravertebral catheters, erectospinae catheters, but the duration of single-shot blocks depends on age, depends on additives, those kind of things. I mentioned in my disclosures, we've had a many-year journey to try to make 2 to 3 day local anesthetics and have been in phase 1 trials, and we are doing the fundraising and business aspect to take them further forward. But I think when they're on an infusion, you want to have a sense of what fraction of a maximum infusion rate you're at, and therefore how far you are from a threshold of toxicity in terms of using additional local. One of the arguments with epidurals of putting additives in, meaning clonidine or opioid, is that the synergism for analgesia doesn't add to the toxicity of the local anesthetic, so that a epidural infusion with hydromorphone, fentanyl, clonidine will intensify the analgesia without pushing you to get to toxic amounts of local anesthetic.
It's been really nice getting into the weeds of diagnosing and understanding local anesthetics. And what's clear to me is that as intensivists, because we don't deal with this near as much as anesthesiologists, we need to work collaboratively with them. So, if it requires a phone call to the anesthesiologist, who's on call or holding the phone, I think it's really clear that we need to work together as a team to manage kids who have these, especially ongoing infusions. So say you're in the operating room and you suspect LAST. Maybe there's no-onset bradycardia and hemodynamic, compromise following local anesthetic, or that more ominous, 20 minutes later after an injection. What are your initial steps in management? And I think perhaps even doing the basics of ABC here is important.
Sure. So the basics of ABC for sure. I think alerting everybody in the room that you suspected that you might need additional help, because when we get far down, there are resources outside the room you may need, but it's also a very high-risk situation. If you're already in that, it's having everyone appreciate, immediately stop what you're doing, cover the room, do whatever, all hands on deck for that. As you say, regarding ABC, all of us who take PALS and ACLS and all, there was that degree to which ventilation became less important, in quotes, certainly in adult CPR and all, but it is a situation where hypoxia and acidosis make it worse, quite a bit worse. They affect the partitioning of where drug goes because of the pKa of local anesthetics. So immediately ensuring that ventilation is maintained, that oxygenation is maintained as a part of it. CPR as appropriate. The part of ACLS protocol or PALS protocol regarding dosing of drugs, it is a consensus recommendation, and one can dispute how strong the animal data are, but that the initial dosing of epinephrine should be reduced. But early on, if you suspect it, along with doing those things, along with supporting the circulation, supporting ventilation, lipid rescue, lipid emulsion has emerged as part of ACLS protocol. It also should be apparent that if you get ventricular tachycardia, that giving lidocaine and probably even giving amiodarone are ill-advised parts of that. Having lipid emulsion available, having everyone have whatever mnemonics are needed, whether it's on your phone, on your cards that are there, but having it available and giving it rapidly is part of the process of resuscitation.
Oh, absolutely. Not going down the lidocaine VTAC pathway sounds very reasonable. And then you mentioned maybe like with bradycardia, poor perfusion or something like that, you would give not the full code dose of epi because of the arrhythmia potential.
And because of animal models of LAST, which suggested better resuscitation with lower dose than higher dose. I think
interesting.
The physiology of it, I think, is of dispute and all, but at least a couple of animal models in more than one species have suggested and have given rise to a consensus recommendation of lower dose epinephrine than standard PALS and ACLS. Whether vasopressin should be used has been suggested. Again, there aren't randomized controlled trials of overdosing people and seeing which work better. So it's an extrapolation from models in several species where those have come from.
The communication aspect here, I think, is really interesting. In managing kids in cardiac arrest, there's so much value for institutions and teams to have a protocolized approach, because for all comers, if you don't know the etiology of arrest and someone immediately starts CPR, someone immediately gets IV access and gives code dose epi, and someone immediately starts ventilating, that's going to help most kids.
Right.
But we're kind of living in this area where, there's actually a pretty sharp differential here. And if we think that local anesthetic systemic toxicity is the likely etiology of this arrest or this, this hemodynamic compromise, it's our job as clinicians and resuscitationists to, I don't want to say go above, but like we should tailor this care to take care of this patient in front of us. And sometimes that might deviate from PALS.
Right.
And the teamwork and the importance of communication and the leadership that's necessary for that. I think that's maybe one of the harder parts of our jobs to pivot and steer an entire team. And thinking about this happening in the operating room, like all of a sudden, you have a team of anesthesiologists, surgeons, and here comes the ICU as well. I imagine communication can be really challenging there.
Yes, it is. I think getting lipid early and using it is important. But let me throw another one at you. The role of ECMO in resuscitation is, if you say most arrests in the OR, unless it's bleeding out, massive air embolism, there are a significant number of kids who get hypotensive or bradycardic, and even before you get to chest compression, it's lighten the anesthetic, ensure ventilation. Those kind of things fix a fair amount of early bradycardia, early hypotension during anesthetics. But pivoting to doing those things, but getting lipid early is one. It may sound like, well, calling the ECMO team stat isn't that rash, but if you don't call early, you're not going to have good outcome. I wanted to mention in the era before lipid rescue, a unique case which is unique for several reasons. And so this happened at the hospital next door to mine in Boston, where there was a relatively healthy woman having orthopedic procedure who got a sciatic block in the popliteal fossa. And she, presumed, was either awake or sedated, but suddenly slumped over and was in arrest. And the very astute anesthesiologist there recognized it as intravascular injection. It was before they had lipid. He also recognized that the next room over had a cardiopulmonary bypass set up and was about to start a heart case, and they literally zipped into that room, went on bypass, and she did fine. But that's not the remarkable part of the case. That's amazing and wonderful. The remarkable thing was the following. This is a digression from local anesthetic, but all of what we now talk about medical disclosure, the anesthesiologist apologized and talked to her over the pressure of the hospital attorney. And this patient and this physician have established together a foundation talking about medical disclosure. For those of you, I can circulate for the group. There's a nice interview with them talking about how they both came out of that situation. And it's a really unique case, but in a way, that's more amazing than that they got onto bypass and that she lived and did fine. That's pretty amazing too, but this is even more amazing. They're public about it. It's just a unique case. And this is more than 20 years ago now, but it was a landmark in thinking about disclosure of critical events that has changed what gets taught to all of us about disclosure and staying in communication with patients and families after adverse events occur.
On the surface, that shows, fundamentally just how potent local anesthetics can be for cardiosuppressant activity. The resourcefulness and the teamwork that's needed to take care of patients in that terrible situation. And then maybe finally, just how therapeutic talking to your patient and your family about what terrible incident may have happened can be so helpful. In the ICU, we're around families in unimaginable situations, and I feel like sometimes they just need to understand why, or they just need to understand what's going on, and try to. Some people at least need to rationalize that, and there might be some aspect of just they need their story to make sense because it seems like they're living in chaos every moment they're in the ICU.
Right.
Yeah. And something that is taught, and I remember learning those lessons, but something that we can always do better at.
Agreed. Let me talk a little bit more about lipid emulsion.
Yeah.
So this was something that started with some both animal work, but then a case of a patient who'd gotten local anesthetic and was getting CPR and wasn't coming back. An out-of-the-box clinician said, I read about this, and they literally gave intralipid, and despite multiple rounds of CPR before, the patient had restoration of spontaneous circulation. You often get asked the question, well, if we're in a OR or we're in an ICU, we have propofol right nearby. Can you give propofol? It's got lipid in it. And if you do the math of how much lipid to how much cardiodepressant propofol, there's so much cardiodepression from the propofol in it that it's not an effective way to reverse the situation. So you need lipid emulsion. One related point that's been mostly in the emergency medicine literature is, let's go back to how does lipid work? The standard, what's called lipid sink hypothesis, and there are competing hypotheses, but it's that bupivacaine in particular, and to a degree other local anesthetics, are lipid-soluble molecules that when you have a bolus of lipid in the circulation, there's partitioning into that lipid phase, and it just, by the concentration gradients, draws some out of the heart in particular. So what came about after it was there are a number of drugs that patients take that people who try to overdose that are lipid-soluble cardiodepressant meds. Tricyclic antidepressants being the classic one, verapamil being another, lamotrigine. And there are these case reports in the emergency medicine literature of people coming, 911 call for someone in overdose, patient is unconscious on arrival, and during transit, lots of overdoses, you restore ventilation, you give naloxone, some people come back or they stay unconscious, but their heart's working. But in a kind of toxidrome where you restore ventilation and you get ectopy, hypotension, all those kinds of features of cardiac depression, in those settings, emergency personnel have given and reversed cardiac arrest from each of those, from amitriptyline, lamotrigine, verapamil, other agents like that. So a great percentage of overdoses are with unknown mixtures of drugs and often occur in people with psychiatric distress, and psychiatric drugs are among those that are cardiodepressant. You know from all the QTCs that you've sent to be measured on your patients that many of them are psych drugs. So it has become a recommendation in emergency medicine that when you have an overdose situation and ventilation doesn't restore stability and you're presenting as a cardiodepressant ectopy situation, that empiric use of lipid makes sense in those. And it'll take you days to figure out what polyoverdose it was or that, but the risk-benefit ratio of giving lipid in that setting seems pretty favorable.
Wow. That's very interesting. And this isn't a small amount of lipids, is it? This has got to be a specific kit or something that you have in the OR, in the ED, pharmacy.
Or a bag, 100 mil adult dose, and assume you do the math as if adults are 50 kilos and all. But a little over is probably better than a little under. And if you are in that situation, risks of lipemia, embolism, pancreatic inflammation, etc., at least in the case series, those have seemed to be low-risk things. And the number of times where it's brought back return of spontaneous circulation are such that I wouldn't be hesitant to use it if you have a high index of suspicion.
A theme that Alice and I try to stay away from is communicating dosing of medicines on the podcast, just because there's a number of reasons, right?
Right.
But do you feel like dosing of lipid emulsion is something that anesthesiologists, something they commit to memory? And whether or not that's the case, do you have any themes for how this lipid is given in the resuscitative period? Like, is this a bolus followed by infusion? Is it repeat boluses? And generally, what are some themes there?
What I would say is, if you have a cart, or if you have like our regional anesthesia carts have lipid on it. Our anesthesia workstations have their list of checklists, or their sets of checklists for situations, and the dose is on that, the volume is on that. I would say the recommendations about the first thing is just to get the first dose in, and then you have time to figure infusion, repeat dose, and if circulation is restored, and then in most cases, it's the first return of circulation that is the biggie. The percentage of cases of an hour or two later repeat cardiodepression, it's more often it's secondary injury as opposed to, I think, repartitioning of local anesthetic. It's getting the first dose in the first place that should be the focus.
Something I didn't make clear earlier in the conversation is when patients develop local anesthetic systemic toxicity, is there a proportion of these patients that just develop bradycardia that you resuscitate, or is it almost universally they arrest? I'm trying to get a sense of, would you use lipids before a child arrests from suspected LAS?
Yes. Well, the cases where that occurs are awake adults. So in obstetrics, if you place a labor epidural and the patient complains of metal taste, tingling, gets kind of twitchy, gets often eye blinking and feeling little bits of myoclonus, particularly because in awake subjects, it can be that the CNS signs precede the cardiodepressant signs. That's the time to give lipid. And even if their cardiac status seems fine, if they're seizing, assisting ventilation early because hypoventilation and acidosis make it worse. So a low threshold for stopping the seizure, and a low dose of a benzo is considered the recommended agent for stopping those kind, rather than levetiracetam, for many kinds of status, levetiracetam, and in a previous era, phenytoin. But because those are blockers of sodium channels as well as part of their actions, a benzo is the recommended agent for seizures with local anesthetic. And with lidocaine in particular, in an awake subject, you're likely to get CNS toxicity well before cardiotoxicity. But awake subjects more and more use the symptom pattern as your trigger for calling for help, calling for lipid, calling for all of what you'd need if it progressed to cardiac depression.
Oh, got it. We're going to stop everything, give you a few minutes, monitor for seizure, and just have the treatment ready to go, but not necessarily push it.
If it is big time tingling, dizziness, even if it's not status epilepticus, if it is a acute mental status change, people can have all kinds of acute mental status changes, but if they say metal taste, tingling of lips and tongue, they're dizzy or they're suddenly disoriented, sedated, right as you're loading a regional anesthetic in an awake subject, assume it to be local anesthetic toxicity till proven otherwise, and I would go ahead and give it if it is the tiniest of symptoms, but when in doubt, or if it's really big-time symptoms, go ahead and give it.
Got it.
I think this is valuable to emphasize. So as I understand it, and correct me if I'm wrong, if you're developing a clinical suspicion of LAST, you're going to send for lipids ASAP. And then your resuscitation priorities are going to be ensuring ventilation is adequate, treating seizures with benzodiazepines. Maybe there's a role for bicarbonate if there's a metabolic acidosis. And if cardiac arrest develops, there might be a role for perhaps lower dose than our standard dose epinephrine. But don't delay giving the lipids if it shows up in the room.
I think that's right. There have been a couple of cases where we've had lidocaine infusions or other local anesthetic infusions. So IV lidocaine is a therapeutic we have. And we've had a couple of patients over many years who developed symptoms on IV lidocaine where we immediately drew a blood level and gave lipid, and the blood level came back not elevated. And what combination of things it was, I don't know, but blood levels take time to come back. Blood gases take time to come back. So if the symptoms and physical signs and hemodynamic monitoring and all are suggestive, you will do better to give it than not give it in most of those settings.
And I think, as a next step for refractory cases, as judged by your story about the woman who was put on a cardiopulmonary bypass, you would suspect a child who develops LAST most of the time probably has normal oxygenation and normal multi-organ function, like they were their OR for an outpatient case. And that's the kind of patient that would probably benefit the most from eCPR. So VA ECMO, as I understand it, is a really good indication, or LAST is a really good indication for that.
Yeah, what I would say is do it in parallel. Even the most ECMO-forward PICUs anywhere, it takes time to call for it, set up all that. You might have a crystalloid prime circuit, whatever. But if you've given the lipid and you're ready to cannulate 12 minutes later, and you get return of spontaneous circulation 12 minutes in, then you apologize, say, thank you very much, sorry, go back to what you were doing. But if they haven't come back, and they haven't come back from a dose or two of lipid and 15 minutes of CPR, better to have called for it early rather than an hour into it, particularly in centers that do that. Places where the cath lab and the OR and the PICU are cardiac ICU are places where it's done with rapid response. At least start the wheels moving.
Of course. Yeah, I mean, hospital systems, we all have to work together, and, it takes a lot of equipment and a lot of personnel to get into the operating room of the ICU to cannulate that patient. And in the meantime, the overview of the initial resuscitation steps for LAST, follow this carefully. We covered lots of good stuff today. Talk about diagnostics, the recognition, the suspicion of LAST, risk factors, initial management steps. I'm kind of moving towards the end of the conversation. Perhaps any pearls, pitfalls you'd like to emphasize for us today?
I think just to review some that we've covered, that when giving local anesthetics, calculate doses, do all the things feasible to stay extravascular, monitor whenever you can. If there are early signs, obviously stop, alert everyone, ensure oxygenation and ventilation. If there's moderately convincing signs pointing to it, have a very low threshold for getting and probably giving lipid. I think those are a bunch of the take-homes. And despite all that, local anesthetics are useful. I think also when you're thinking about risk, thinking about disease-related factors, think about other cardiodepressant meds, think about a patient who's taking mixilotine probably should get less local anesthetic because it is a local anesthetic. So think about actions of other drugs on cardiac ion channels in particular. Those are a few.
Well, Dr. Berde, thank you so much for joining us today.
Sure. Pleasure.